This is a case of a 23-year-old male who has a minus 22 diopters in one eye and minus 22 with two diopters of cylinder with iris coloboma. The patient had intense glares and halos even with glasses, and he had been going to other people to ask for a refractive surgery, but for some reason people did not agree to do any refractive surgery for him. The only thing they could recommend was probably doing a clear lens extraction for a refractive correction with the IOL. Now, we took this patient up after the calculations. His anterior chamber depth was 2.86. Now, proceeding to the case, you have to be very, very careful that you do not overpressurize chamber with viscoelastic in these cases. No hard pressure on the lens, crystalline lens. Overpressurizing with the anterior chamber with viscoelastic in this situation can cause the viscoelastic to seep into the vitreous, because from the inferior area, the zonules are weak, as you can see. Another thing is that very, very gentle manipulation of the haptics behind the iris. Now, IPCL is excellent in these situations, especially for toric IOLs, because in these situations you will not have the luxury of being able to dial the lens, especially if it's an ICL, and whereas an IPCL comes as a smart toric IPCL and it just goes placed at 0 180, so you don't need to dial or rotate these particular lenses. Now, since this particular part of the surgery is simple, we have done the phakic lens implant. In this case, I have put a miotic agent. I'm just waiting for the pupil to shut down. Always remember before you do pupilloplasty to shut down the pupil with a miotic. Now I've rotated the microscope and I've gone on the superior side. So please note that I did the surgery from the temporal side, and now I've moved on to the superior side of the patient. I create a side port on one side, and there is already a pre-existing side port on the other side. Now, taking a 26 gauge needle, you remember to bend it at the terminal edge of the 26 gauge needle with the bevel facing up. The bend should not be more 60 to 70 degrees, otherwise, especially it will start sticking onto the nasal side of the patient if you're coming from the nasal side. The second side port is made. Now, this side port will be used to hold the iris before piercing it with a 10-0 Prolene straight needle. One thing to remember is when you are trying to put in this needle straight through the wound, try and hold the needle as near to the sharp edge and have a shorter flange of needle to manage. Otherwise, a longer flange needle is very difficult to manage. Second tip is do side to side movements as you're going through the wound, because sometimes accidentally you can go through the cornea or the scleral tissue and then you land up in trouble. So you will notice I'm doing side to side movement to make sure that the needle is actually gone through the wound itself and not through the tissue of the sclera or the cornea. Now, having done so, this patient is very, very uncooperative. I've given him a block, but still for some reason the block is not adequate. Now he's continuously rotating the eye upwards, and I'm sitting on the superior side. I will try and engage in one go with the needle, but unfortunately I'm unable to do so. You will see I will go through once, but it doesn't work because the patient is not giving me the right dimension again. So now I hold the needle again near the terminal edge. I use a retinal fine forceps, hold the iris at one area, pierce the needle approximately 500 to 600 microns from the sphincter edge. Make sure that I do it once and I leave it like that. Now, this is a very, very critical step. If the patient starts moving, you can actually injure your cornea. And now, making sure since the patient is moving, I push the needle further into the eye, because I don't want the patient to be rolling up the eye and my needle coming out again. Now, I will fast forward this particular step. We push in more viscoelastic. Now, through the fourth side port, I again use the fine forceps, retinal forceps, ILM peeling forceps to hold the tissue just near the edge and go through this part of the iris with a 26 gauge needle, which was bent by me. You can also pierce it straight with a needle, but in this particular situation, my patient is very, very uncooperative. So I prefer using a 26 gauge needle here. Now we proceed to do the railroad technique. You can notice the patient is trying to roll his eye upwards. I'm trying to push the eye down. The patient is lifting his chin up with the railroad technique. Now also remember that while you're doing this particular step, you have to be very, very careful that you pull the needle out straight. Now once this is done, you can use a Sinsky or even your ILM peeling forceps to go and hook the loop out from the side port 2 through which your 26 gauge needle went. Now I brought the loop in. You have to be very sure. Don't pull this loop very hard, otherwise the suture may cheese wire through the iris tissue. In this particular situation, the patient is very uncooperative. He's rolling up his eyes again and again. So I'm doing it very, very carefully and gently. Now, since the loop is out, I pull the loop out very gently, and now I'm trying to pull the loop from the free side of that suture so that I don't cause much traction on the iris tissue. Now you can see the loop of the suture is there. The other edge of the suture is now going to be trimmed so that I have a shorter suture length. Now we will pass this loose cut end of the suture through the loop 4 times in the same direction. You will notice I will straighten up the suture, clear the loop, hold one edge of the cut end of the suture, go with one forceps, McPherson forceps, through the loop, hold the cut end of the suture and pull it out. That's your first pass. Now the same step is repeated for the second pass. Again, bring out the loose cut end of the suture through the loop. That's your second pass. Again, go through the loop with your McPherson. Hold the suture for the third time. This is your third pass. Now for the final pass, you again do the same thing in the same direction. Always remember to keep doing it in the same direction. This is very, very important. Otherwise, your suture will open inside the eye once you open up. Now, very gently pull on both the sutures with equal force so that you tighten the knot in the anterior chamber. Do not over tighten this knot, because if you over tighten this knot, you will realize you will cut through the iris tissue. Slowly titrate the tightness of the knot and then leave it. Now, all you need to do is make sure that your knot is closed, tightened, and in center. You will notice that the pupil has become beautifully round in the center. Now you put viscoelastic. Now using fine 23 gauge scissors, you have to be very, very careful when you now go and trim your sutures. You may end up cutting the knot and you will have to do the whole step again. Cut the knot very short, approximately 300 to 500 microns long. Both the loose edges of the knot have been cut. Now, don't suddenly pull the suture out, because sometimes the knot, you might not have cut the suture and you'll pull the whole iris out. Ensure that the knot has been cut, like here. I thought I'd cut the knot, but it was not cut. Luckily, I didn't pull the suture out. Otherwise, I would have pulled the whole iris out and caused iridodialysis. Now, the other part of the suture, again, we have to ensure that it has been cut away from the knot, and only then you start pulling out that suture, so that now you just have a beautiful centrally round pupil. There, my suture was trimmed properly. I pulled it out. Now I go in to do a bimanual irrigation aspiration of the viscoelastic. You will notice that the pupil is round, central. The inferior part of that area which is exposed is usually covered by the lower lid. You don't need to do any extra suture. But in case if you need to, you can repeat the same step and give one more closure suture inferiorly. Do two knots. And there you see the case has been done beautifully. This patient was extremely happy, and after 3 days, I operated the second eye with a toric lens. Both eyes, he did fantastically well. He was super happy, and so was the surgeon. The patient recovered excellent vision of 6/12 on 7th day in one eye and 6/9 on other eye. Thank you.